Hey everyone, and welcome. Today, we're jumping right into a highly focused, totally comprehensive explainer on two major, heavily interconnected neurological conditions. We're looking at agenesis of the corpus callosum and the absence of the septum pellucidum. We're going to go point by point through the essential anatomy, the underlying pathology, and exactly how these neural midline anomalies present in a clinical setting. Here is our roadmap for today. We'll start with corpus callosum agenesis basics, incidence, and neuropathology, followed by the clinical presentations. Then we'll shift gears to examine the absence of the septum pellucidum, its etiologies, and we'll finish up with a detailed breakdown of septo-optic dysplasia. All right, section 1, corpus callosum agenesis basics. So the absolutely crucial thing to understand right off the bat is that this condition starts incredibly early in embryological development. Agenesis of the corpus callosum, or ACC for short, is fundamentally a failure of commissuration. Basically, the vital nerve fibers that are supposed to cross the midline to connect your two cerebral hemispheres, they just fail to develop. And this failure happens at roughly 2 weeks after conception. That early disruption literally sets the stage for a massive cascade of structural changes in the brain. Structurally, what does this actually look like? Well, because that giant bridge of white matter isn't there to hold everything in its normal anatomical place, the third ventricle literally expands upward. On top of that, the lateral ventricles are pushed completely apart. If you're looking at neuroimaging, you'll specifically notice that these separated lateral ventricles develop distinctly dilated occipital horns and atria, and they'll have these noticeably concave medial borders. Now, there's a really fascinating exception to the normal growth pattern here, and it serves as a massive diagnostic clue. Normally, the corpus callosum forms from front to back. It starts at the rostrum and genu and grows backward toward the splenium. So in typical agenesis, you might see the front part exist while the back segment is missing. But if you see the exact reverse, meaning an absence of the anterior corpus callosum but some posterior portion is actually present, that completely flips the expected developmental script. That specific finding is highly indicative of some form of holoprosencephaly. Moving right along to section 2, ACC incidence and neuropathology. You might be wondering, how often do we actually see this? The incidence is roughly 1 out of every 2,000 to 3,000 neuroradiological examinations. So while it is technically a rare congenital anomaly, it's absolutely something you'll encounter in clinical and radiological practice. You definitely need to know how to recognize it. Now, ACC rarely happens in perfect isolation. To make sure we don't skip over any important concepts, let's break down the associated pathologies point by point. First, it's often accompanied by porencephaly, which are basically cysts or cavities in the cerebral hemisphere. Second, you might see microgyria, where the brain's folds are unusually small. Third, we always look for fatty tumors, specifically interhemispheric lipomas and lipomas right on the corpus callosum itself. Fourth is anencephaly, which is the absence of the olfactory bulbs and tracts. And fifth on this list is optic atrophy, indicating degeneration of the optic nerve. Let's continue point by point through these anomalies. Next up, we can see coloboma, which are missing pieces of tissue in the structures forming the eye. Moving deeper into the brain, there can be hypoplasia or underdevelopment of the limbic system. Now, pay special attention to this next one because it's a truly fascinating pathology. The bundles of Probst. These are literally the aborted beginnings of the corpus callosum. Since those fibers couldn't cross the midline like they were supposed to, they just run front to back instead, bulging noticeably right into the lateral ventricles. And because of that massive architectural shift, the typical horizontal orientation of the cingulate gyrus is completely lost. Rounding out our pathology list, we have schizencephaly, which involves abnormal clefts in the cerebral hemispheres. The anterior and hippocampal commissures may also be totally or partially missing. You will often see hydrocephalus, along with cysts localized right in that corpus callosum region. It can even be linked to major neural tube defects like spina bifida, either with or without a myelomeningocele. And finally, ending this extensive list is the absence of the septum pellucidum, which perfectly sets up the second half of our deep dive today. Section 3, Clinical Presentations of ACC. So how does a patient with all this actually present? Well, it varies wildly. They might present with hydrocephalus or microcephaly, which is an abnormally small head. While seizures can happen, the literature explicitly notes that they're actually quite rare in this specific context. You might also see endocrine disruptions like precocious puberty. Now, logically, you might expect a severe disconnection syndrome where the left and right sides of the brain simply can't communicate.
But interestingly, the data tells us this syndrome is way more likely to occur with an acquired corpus callosum defect, like from a surgery or a stroke, rather than this congenital agenesia. In congenital cases, the developing brain literally has the time to compensate and wire around the defect.
You also have to keep in mind that ACC might just be an incidental finding. All by itself, it could have absolutely zero clinical significance, and a patient might live their whole life totally unaware of it. However, it can also anchor some really complex chromosomal abnormalities and syndromes. A prime example is Aicardi syndrome. This is characterized by a very specific tetrad: agenesis of the corpus callosum, seizures, mental retardation, and distinctive patches of retinal pigmentation.
All right, moving to section 4, absence of septum pellucidum.
So the septum pellucidum is that thin, triangular, vertical double membrane that separates the anterior horns of the left and right lateral ventricles. When this midline structure is completely absent, it's almost never just a standalone issue. Instead, think of this missing membrane as a crucial diagnostic breadcrumb. It's a huge red flag, heavily signaling that we need to be looking for other, much more complex neurological syndromes.
Let's look at section 5, etiologies of absent septum.
We are going to meticulously list out the 8 known etiologies for this absence, point by point. The first 4 causes directly tie back to major structural anomalies, some of which we've just talked about. First is holoprosencephaly, where the forebrain fails to divide into 2 distinct hemispheres. Second is schizencephaly, which are those abnormal brain clefts. Third, as we literally just established, is agenesis of the corpus callosum itself. And fourth is the Chiari type 2 malformation, which involves the downward displacement of the cerebellar tonsils right through the foramen magnum.
Continuing point by point, the 5th etiology is a basal encephalocele, a rare neural tube defect. 6th is porencephaly or hydranencephaly. Now, the 7th point is honestly fascinating: severe hydrocephalus. In this specific scenario, the septum pellucidum might have actually formed perfectly fine initially, but the immense fluid pressure causes necrosis and subsequent resorption of the septum. It basically gets destroyed from the inside. And finally, our 8th etiology is septo-optic dysplasia, which is a condition so significant it absolutely requires its own dedicated breakdown.
Which brings us to our final section, section 6, septo-optic dysplasia breakdown.
Septo-optic dysplasia is also known in the medical literature as de Morsier syndrome. Fundamentally, this arises from incomplete early morphogenesis, meaning physical development, of the anterior midline structures of the brain. Now, it is a spectrum disorder, so its severity can definitely vary, but it strikes right at the core of the brain's central architecture.
The physical reality of this syndrome is pretty stark. Let's go through it point by point. First, it produces hypoplasia, or underdevelopment, of the optic nerves and often the optic chiasm. Because of this, affected patients are typically blind. Second, there's hypoplasia of the pituitary infundibulum. That's the stalk connecting the hypothalamus to the pituitary gland. Third, and this is interesting given the name, the septum pellucidum is actually only absent in about 50% of cases. And fourth, about half of these cases will also present with schizencephaly.
Because you have that direct pituitary involvement, the clinical presentation is heavily driven by secondary hypopituitarism. The endocrine presentations run the entire gamut. You might see dwarfism or just an isolated growth hormone deficiency, or it could be as severe as panhypopituitarism, where basically all pituitary hormones are deficient. Occasionally, it swings completely in the other direction, resulting in the hypersecretion of growth hormone, corticotropin, or prolactin, and that can lead to precocious puberty. But here is the wild part regarding cognitive function. Despite these massive structural deficits, intelligence can remarkably remain completely normal in most patients, though mental retardation certainly can occur in a subset of cases. Clinically speaking, you really have to view septo-optic dysplasia as a potential variant of holoprosencephaly. It's often a less severe form, though sometimes it does occur as part of the full holoprosencephaly anomaly, which unfortunately carries a much poorer prognosis for both function and survival. From a neurosurgical perspective, the ventricles in these patients might look perfectly normal, but they can also be distinctly dilated. When you see that dilation, it immediately raises concerns for possible hydrocephalus, meaning you need close monitoring and potentially surgical intervention. We have covered some incredible ground today, from the early developmental failure of the corpus callosum, all the way to the hormonal chaos of de Morsier syndrome. As you synthesize all this strict criteria we've detailed point by point, ask yourself this. Given the profound interconnectivity of these anomalies, how does one single missing membrane, An isolated finding of an absent septum pellucidum shift your entire clinical approach. It kind of changes everything, right? It turns a simple scan into a hunt for connected syndromes. Thank you so much for joining me on this deep dive today. Keep questioning, keep learning, and I will see you in the next explainer.